Welcome to this session all about pre-symptomatic ataxia. My name is Dr. Celeste Seward. I'm the Patient Engagement Manager for the National Ataxia Foundation. And with that, it is my absolute privilege to introduce our two speakers today, Emma Snyder and Dr. Marie Davis. So Emma Snyder is a licensed board-certified genetic counselor practicing in the areas of neurogenetics and general adult genetics. She attained her Master of Science in Genetic Counseling at the MGH Institute of Health Professions in 2022. After which she joined the team at the University of Washington Medical Genetics Medicine Clinic. Her interests include hereditary movement disorders, including hereditary ataxias, hereditary cardiomyopathy and arrhythmia syndromes, as well as LGBTQ+ inclusive healthcare. And Dr. Marie Davis is a board-certified neurologist who specializes in genetic movement disorders. Dr. Davis is an associate professor in the Department of Neurology at the University of Washington School of Medicine. She's also a staff neurologist and a basic science researcher at the VA Puget Sound healthcare system, in a lab that focuses on the genetic influences of Parkinson's disease. Dr. Davis believes in a multidisciplinary approach to patient care, often including physical, occupational, and speech therapy, as well as caregiver education, social work, diet, and exercise. Her number one goal is helping patients maintain the best quality of life possible. Dr. Davis's clinical interests include movement disorders due to genetic causes, such as hereditary ataxias, dystonias and Parkinsonisms, Huntington's disease, and hereditary spastic paraplegias. And with that, Dr. Davis, Emma, the floor is yours. Thank you for joining us today.
Fantastic. Thank you so much, Celeste, for that introduction. Good morning, good afternoon, good evening, depending on where you are in the world. We're so excited to be here. Again, my name is Emma Snyder, genetic counselor here at the University of Washington Medical Center. And we're excited to speak to you today all about pre-symptomatic ataxia. So I will get us started.
Yes, just say thank you as well. Thanks for having us. And yeah.
Excellent.
Emma and I work as a team in clinic, so we will work as a team for this.
Exactly. Perfect. Well, before we dive into genetic ataxia specifically, I wanted to make sure we're all on the same page about some basic genetics concepts. So as you may know, our genome is essentially the instruction manual that tells our body how to grow and develop and function. And we can think of our genome, which contains over 20,000 genes, like an encyclopedia. And we get actually two copies of this encyclopedia, one copy from mom and one copy from dad. So our genetic information is inherited from both parents. And if we zoom in on one of the books in an encyclopedia, there's going to be several sentences. And we can think of each sentence as a gene. And what the gene does is it produces a message that then goes on to encode a protein. And that protein is going to perform some kind of function in the body. And it's really important to help operate the machinery that tell our cells and our body as a whole what to do. And so you could imagine that if there are variants or mutations in a gene, that this would impact how the gene functions. And so if we use the analogy of a sentence, for example, Seattle is a rainy city, this is spelled correctly, it has the right grammar, and so this will go on to produce a normal functioning protein. But there are many different ways that a sentence can be misspelled. This could be a substitution of one of the letters. It could be an expansion or a repetitive region that is too large. It could be a deletion or duplication. These are just a few examples, but all of these things may lead to an abnormal protein or an absent protein. And while there are many different types of mutations that can cause a genetic ataxia, the one I want to focus on today is what we call a repeat expansion, as many genetic ataxias are due to a repeat expansion. I'll talk a little bit more about this. So like I said, there are many different types of genetic ataxias that are often caused by this repeat expansion. And what I'm showing here is a representation of this repeat expansion. And up top, we have these CAG repeats, which we call short tandem repeats or STRs. C's, A's, G's, and T's are the building blocks of DNA, which is what genes are made of. And in some genes, we all have a repetitive region. that is normal for that to be there, and it can have a range of what is normal. But when someone has too many repeats in a certain region in a gene, depending on the gene and depending on, depending on the gene, we can see signs and symptoms of ataxia when that region is expanded. And so what the bottom of this image is showing is when that expansion is present. There are many, many, many CAGs. So that would be like Seattle is a rainy city, and so on. And when we're doing genetic testing for this type of genetic ataxia, we're essentially counting the number of repeats that are present. So now that we have some foundation in genetic ataxias and repeat expansions, I want to switch gears to talk a little bit more about pre-symptomatic ataxia specifically. And so when we're talking about pre-symptomatic ataxia, we're referring to someone who is not yet showing symptoms, but has a genetic mutation that will eventually cause the symptoms of ataxia. And what we know is that many genetic causes of ataxia show high penetrance, meaning there's a high likelihood of developing symptoms, but much of the time we can't predict what those symptoms exactly will be, when they will present, exactly how someone's disease progression may go. And sometimes there's a repeat number range that shows lower penetrance depending on the gene, which means that some people with a repeat number in that range may not develop symptoms. And so that can certainly complicate the discussion a little bit as well. In terms of how genetic ataxias are inherited, even if someone is only pre-symptomatic for an ataxia, if an individual has a genetic risk for ataxia, they can still pass this on to children. And the most common inheritance pattern we see with genetic ataxias is autosomal dominant, meaning that there would be a 50% chance to first-degree relatives, children, parents, siblings, to have that same genetic mutation and the risk for ataxia. But there would also be a 50% chance to first-degree relatives to not have inherited this and to be at general population risk for ataxia, which is overall quite low. There are some non-genetic causes of ataxia, but the risk would definitely be lower than if someone had a positive genetic test for a known ataxia in a family. And so to illustrate what this might look like in a family, I'm showing here a pedigree or family tree of what a dominantly inherited ataxia can look like. So this would be where there's a variant in one of two copies of a gene. Remember, we get 2 copies of that encyclopedia, so 1 copy of each gene from mom and 1 copy of each gene from dad. And in dominant conditions, you just need 1 of the 2 copies of a gene with a mutation or variant to cause the condition. And so this would be like if 1 copy said Seattle is a rainy city, and the second copy just says Seattle is a rainy city, normal spelling of the gene. And some hallmarks of dominant inheritance can include, multiple generations affected with the condition and the passing of the condition from a parent to child. Now, for these individuals in purple who are affected, each of their children would be at 50% chance to have the same mutation and the increased risk for ataxia. And the folks who are drawn in white are not affected. And so it's not drawn here, but this individual would not be able to pass down the genetic mutation in the family because she is not affected and did not have a genetic mutation. And so it would stop with her in this family, whereas anyone in purple, like I said, would have that 50% chance to pass it down. Although here it's shown that all 4 of this person's children did have the condition. But this could have easily have been 3, 2, 1, none of the children. It's 50% chance with each offspring. And although it's less common for repeat expansion ataxias in particular, I did want to show what a recessive pedigree can look like too. So this would be where there's variants in both copies of a gene, and that's what's needed to cause a genetic condition. So this would be like if 1 copy said Seattle is a rainy city and 1 copy said Seattle is a rainy city. So mutations in both copies of the gene. And when we see this inheritance pattern, we can see siblings who are affected. but usually neither of their parents would be affected, and it would be very unlikely that they would pass it on to their children. However, each of these parents here would be considered unaffected carriers, meaning they just have one mutation. And so for their children to be affected, they each would have had to pass down the copy of their gene with the mutation. And so if one of these individuals had children with someone who was an unaffected carrier, then there would be a risk to offspring. But the likelihood of that happening is overall quite low, depending on the condition. I thought it might be helpful to talk a little bit about how we approach genetic testing and evaluation for pre-symptomatic ataxia in our clinic. We utilize a 3-visit process, which is modeled off of the 3-visit protocol that the Huntington's Disease Society of America uses. This is because Huntington's disease is another neurodegenerative condition that also, can certainly impact one's health, and there is not a clear treatment or cure similar to many genetic ataxias. And so we use this process to really help folks through the genetic testing process and make sure that they are making this decision carefully. And so typically the first visit in this 3-visit process would be a discussion with a genetic counselor, such as myself, about what the individual knows about the condition in the family, and to learn more about the science of it, the inheritance, as well as genetic testing considerations and evaluating what is important to the patient and why they think they want to get tested. The second visit, if a patient would like to proceed, would be a physical exam with a neurologist and another opportunity to ask questions, particularly about management and research. And if an individual would like to move forward at that time, we can do a blood draw for the genetic testing. Depending on the gene and depending on insurance considerations, this usually takes about 2 to 4 weeks to get results. And then during a third visit, this would be when we actually disclose the results. So this is usually over telemedicine or in person. But we really try to avoid sending it out in writing or just over the phone, as we really like to provide real-time support to patients when we're giving the results to them whenever possible. One of the big considerations that we often get asked about and that we think is important to emphasize has to do with genetic discrimination. So there's a law called the Genetic Information Non-Discrimination Act, or GINA, and this is a law that was passed in 2008, and it protects against use of genetic information by health insurance and by one's employer. So what this means is that with a positive genetic testing result that increases risk for ataxia, one's health insurance cannot discriminate, drop coverage or raise premiums based on that result, and an employer cannot fire or otherwise discriminate based on that result. However, some supplemental insurances like life insurance, long-term care, and disability insurance are not protected under this law. And so theoretically, those insurance types can ask for medical records, which would include a copy of a genetic test result, and can use that information to make a determination about coverage or premiums. It's not so much that they will, it's that they can. And we hear varying stories from our patients. Some people say that they haven't been asked about family history when they've tried to apply for life insurance, for example, so it didn't come up, so they didn't have to share it. Versus others who have told us it was very difficult to obtain. And so what we often will try to recommend to families, let's say we diagnose an individual with a genetic ataxia in our clinic, we try to advise that if any of their relatives are interested in genetic testing, particularly if they're pre-symptomatic, to try to look into these policies before bringing this up with their providers, so that it's not anywhere in their medical record, if that can be avoided, to give the best chance of being able to obtain these types of policies. Some important exclusions for GINA are that it does not apply to veterans or active duty military, and it does not apply to individuals on an individual health insurance plan versus a group health insurance plan, which is the type that most employers would use. This is just the way the law was written, and it's not clear why these exclusions are in place, but again, a law can be written in any way, and this is just how it was written. I will say that some states do have additional protections against genetic discrimination beyond what GINA protects. Here in Washington, I don't believe we have additional protection, but I know in other states there can be additional protection. So I would definitely look into that in your state if you have additional questions about that. And for more information in general, GINAhelp.org is a great resource. And if it's something that's accessible to you for more detailed questions, we often recommend trying to seek out support from a lawyer if that's something that you have more specific questions about, particularly someone who's well-versed in genetic discrimination. And so what else should someone consider before pursuing this process to learn if they're at risk for ataxia? These are all questions that we often will talk about with patients both during the first and second visit. But some of the things are, what are my primary motivations for pursuing genetic testing? For a lot of people, we hear that they want to reduce uncertainty in their life, plan for the future, no recurrence risks for children. Sometimes even they're very interested in research participation. And so that can sometimes be a partial motivation to pursue genetic testing. Another question that we ask people to consider is if they want to know their status if they don't have symptoms. Depending on the age at which they get tested, they may not develop symptoms for decades. And that can be something difficult to hold on to know that you're at risk, but have this sort of waiting period that can lead to increased anxiety, but for some people might help them feel more in control that they have that advanced knowledge. A lot of the dominantly inherited genetic ataxias are adult onset, and so we typically do not facilitate genetic testing for individuals who are under 18 unless there is a chance that they may have symptoms in childhood to preserve their autonomy and not to over-medicalize a child for an adult onset condition. Another question that we ask people to consider if now is the right time to pursue genetic testing. You may know that genetic testing is something you'd like to pursue, but it could be that there's a big life transition coming up and there's added stress because of that, and this would, add to that. Or you just completed a big life transition and you're feeling in a more stable place and you feel like now is a good natural pause to think about this. So sometimes it's not necessarily about whether to pursue this testing, but when as well. We'll often also ask people to consider how it would feel to test positive, meaning that they do have the genetic risk for ataxia, kind of sit with that feeling for maybe a day, walk around as if you tested positive and see how that feels, what comes up for you. And similarly, how it would feel to test negative. We often hear from patients in the pre-test phase that they would feel relief, certainly, but there can also be other feelings that come with a negative result. For example, genetic ataxias can affect a whole family. And so if someone has a negative result, and let's say their sibling has a positive result, that can certainly bring up some complex feelings as well. So just asking people to think about how those scenarios might feel for them to be prepared. And then, of course, how might this information affect my relationships and day-to-day life and mental well-being in general, to try to envision, possible outcomes from this testing in terms of those factors. So I'm going to pass it over to Dr. Davis to talk a little bit more about what happens after genetic diagnosis and some of the considerations medically for pre-symptomatic folks.
Yeah, thank you so much, Emma. That was a great overview and intro. And as Emma kind of alluded to, what happens after you get that pre-symptomatic genetic diagnosis. And this is mainly for people who find out they do carry the genetic cause of ataxia. I tend to see people have two main courses. One where people want to just check in with me every maybe 1 or every 2 years, just to just to check in kind of whether I think they're having symptoms, whether or not they think they're having symptoms, and also updates on research and treatments and kind of the latest. And I'm always happy to do that. There's also people who don't want to think about it anymore. They got the result, they want to move forward with their life. And then once they think they might have some symptoms that might suggest onset of ataxia, then they'll come back to me, and that might be in 2 years or 5 years or 10 years. And that's totally fine course as well. So it's just very personal, decision. And I think I've heard some people say, well, I just want to check in with you every year because I don't want to kind of put it on myself to decide, am I starting to have symptoms or not? I just want to, have you kind of evaluate me. And that's totally fine too. So he said that there's updates in research, and I think you've probably heard this from other webinars and information, but pre-symptomatic people are actually kind of a target for early interventions and treatments for these neurodegenerative conditions. There's the feeling that once people start um, manifesting symptoms, there may already be significant damage to neurons in the brain and nerves, and that really the effectiveness of interventions may be best at pre-symptomatic stages. So pre-symptomatic people are really actually kind of a high priority population for a lot of um, pharmaceutical trials, as well as non-pharmacologic trials, which I'll actually mention. And the goal is, not just maybe reducing symptoms, but also delaying the onset and actually really changing the course of the disease, either slowing the progression or halting the progression, which would be amazing. And maybe even delaying, onset of symptoms. Actually, let's go to the next slide. So I was saying, pharmacologic treatments, but also non-pharmacologic treatments. And I think, one of the biggest ones right now that's here and available is exercise. And there's just been tons and tons of research on exercise in ataxia, as well as many other neurodegenerative conditions like Parkinson's, Alzheimer's, Huntington's. And basically, there's just been an overwhelming conclusion that exercise is really helpful. It's hard to totally prove that because we can't really do a placebo exercise. There's so many other things that go into exercise. There's the social aspect, if it's a group-based exercise or social kind of interaction involving exercise as well, or if exercise involves going outside, then there's all the environmental influences of getting outside, getting fresh air as well. That could be influencing that, but it's very clear exercise has a very positive effect on neurodegenerative conditions, including ataxias. These are just two examples. They're older examples. I like this one with video-based game exercise because it doesn't just mean you have to go to a gym. You could even exercise in your living room with your Wii or Xbox Connect. And these studies actually showed really good effect on the scales we use to measure motor symptoms of ataxia. And go ahead to the next slide. And I put this slide just because there is basic science, validation of why we see benefit in exercise. So this is looking at a mouse model for spinocerebellar ataxia type 1 and actually seeing some epigenetic changes that are affecting the disease process in these mouse models when the mice are exercising more. So it's not just kind of subjective or rating scale measures. There we have actually some biological basis for this. Go ahead to the next slide. And then this is something I just kind of wanted to show. I would say, again, take this with a grain of salt because this was only a study involving, I think it was about 45 patients and looking at people who had higher VO2 max levels, so higher like kind of oxygen consumption levels for related to their exercise and fitness level compared to lower levels and people who are more sedentary with ataxia. And they just correlated that people who had this like kind of higher physical activity level were associated with lower ataxia kind of symptoms. But again, this is a correlation. This is a snapshot. Of course, there's a lot of kind of what's the chicken, what's the egg, you know. So I just wanted to mention this, but not, you know, I would say take it with a grain of salt. It's also a small study. It didn't reach, you know, clinical significance, but it just kind of, I think, is another support that exercise is very much correlated with, you know, positive effects. Yeah, next slide. So I think those are kind of our main points, and we're leaving lots of time for discussion. I think I already see lots and lots of questions, so we're happy to answer them. But just some take-home points is that getting tested when when you're not yet showing symptoms, but you know you're at risk, it's a very personal choice, and you have to just kind of really consider your own individual you know, context and reasons for doing it, and you know, whether it'll be helpful for you or not. And we're here to help, you know, try to guide you through that process. I think the people who tend to get pre-symptomatic genetic diagnosis, they cite that this is helpful for them for financial planning, for family planning, and overall future planning. And also, as Emma said, often part of the motivation is to also potentially participate in research. And actually, even if you test negative, a lot of times the research studies need, you know, control groups of people who don't carry the genetic risk. And so even if you test negative, it doesn't necessarily preclude you from participating in research. And then in terms of early stage therapeutic interventions, there are a lot of things coming down the pipeline. And I didn't really want to talk about all of these different kinds of things just because there's so many and they're not really, you know, clearly well, first of all, they're in clinical trials or they're preclinical. But the thing that is out here and you know, totally available is exercise, and we have a lot of evidence suggesting that this is helpful. Whether it really truly, you know, can slow progression or even delay onset, we don't totally know. But and that's really hard to pin down. But it is a very promising early stage kind of intervention.
Happy to take questions.
Wonderful. Thank you so much, Dr. Davis. Thank you, Emma. We will move to our Q&A. So our first question is a clarification question around genetics topics. So we have someone who's asked, so my question is about ataxia types. Is each type, let's say SCA8, for example, specific to repeats, or could it be multiple different kinds of mutations like repeats, errors, deletions, etc.? Could you clarify this?
Yeah. So I think, as if I'm understanding the question correctly, each type of ataxia typically has a specific type of mutation that can cause the condition. So for SCA8, for example, spinocerebellar ataxia type 8, that would be due to a repeat expansion type of mutation, as far as we know. Do you have anything to add, Dr. Davis, or does that cover it?
Yeah, I mean, so we have this kind of large focus on repeat expansions, and so but there are definitely genetic ataxias due to um, uh, kind of changes in the spelling of the gene more. Those are less common. And so when that's the case, there can be a lot of different types of genetic changes, rather than just looking at this kind of number of repeats that's found in your two copies of the gene. So yeah, I think that maybe that's part of the kind of confusing aspect is when it's not a repeat expansion ataxia, when it's more due to various different types of kind of mutations, spelling mutations or small deletions or small kind of rearrangements, then there can be a wide variety of changes.
And we do have some follow-up questions around repeat disorder specifically, as well as genetic anticipation. So perhaps to start off, could you just let the audience members know some of the SCA types that are caused by polyglutamine repeat expansions, the most common ones, just so that they can know if theirs is a repeat expansion disorder or if it's not?
Yeah. Or did you want to take it or should I?
Oh, you can go. Yeah.
Okay. Some of the common repeat expansion spinocerebellar ataxias would be SCA type 1, 2, 3, 6, 7, 8. There are a handful of others that can be due to repeat expansions. One of the more newly discovered ones that we're learning is very common would be spinocerebellar ataxia type 27B. There are many, many types of spinocerebellar ataxias, and some are due to repeat expansions and some due to other types of mutations. But those are kind of the heavy hitters, I would say.
And for folks who do have repeat expansion disorder related ataxias, could you clarify what it means to have genetic anticipation and how, when their parents experience symptoms, how that might relate to when they first experience symptoms?
Yeah. Do you want to speak to that, Dr. Davis?
Yeah, sure. Oh, I just also want to mention that repeat expansions can occur in recessive
That is
ataxia.
true.
Yes.
So they're not all dominantly inherited. So for anticipation, I think that is something that, it's definitely in textbooks, medical textbooks, a lot on the internet, a lot, but we don't always see that. Like, actually, I would say it's a minority of families where we really see that clearly. A lot of times we see pretty similar. So anticipation means that when the condition is passed down from one generation to the next generation will manifest symptoms earlier and perhaps more severe compared to the prior generation. And that's mainly due to repeat expansion conditions, because the size of the repeat expansion is somewhat correlated to the age of onset and kind of severity of the disease. And so as it's passed down from one generation to the next, the expansion can get longer due to kind of replication instability of that repetitive sequence of DNA. But yeah, to be honest, I think a lot of times we don't see a huge difference between generation to generation. However, there are certain repeat expansions where we sometimes see a sort of correlation between which parent passed it down. So for example, if it tends to come from dad, sometimes there might be a little bit increased risk of expansion from one generation to the next versus inheritance from mom. But it can go either way. So I know SCA 27B tends to be the opposite, where if you inherit from mom, it might be a increased chance of expansion to the next generation. Anyway, I would say overall it's like not super common, even though it's kind of well recognized and put out there in the literature a lot.
Very good to know. We've had a number of people ask similar questions, just asking you to go over again, what kinds of things can people do preemptively if they know they are pre-symptomatic, but they're not currently experiencing symptoms. You mentioned exercise. Some people have questions around should they preemptively start speech therapy, PT, OT, if there's any supplements they should be taking. Could you give us a little bit more information around once someone has that diagnosis, but they're not yet experiencing symptoms, what kind of lifestyle changes or medical changes they can make ahead of time before those symptoms start?
Yeah, why don't I take that? So yeah, I would say just be as healthy as you can. And in terms of PTOT speech, if you aren't really experiencing any major motor or speech issues, I don't think that those therapies will be super helpful. They only become helpful once you start manifesting symptoms and having more difficulties. Um, but that I think it's a great time if you're not already physically active to really kind of start taking advantage of that. And then those people who are already physically active, I just encourage them to keep it up and try to be as healthy as you can. People often also ask me about diet. Again, there really hasn't been shown to be any specific diet or supplement that's been super helpful. There's been a lot of study with coenzyme Q10 because that um, is um, is a molecule that's involved in mitochondrial health and has been implicated in neuronal health. And so theoretically, it would make a lot of sense that it would be helpful, but there's been a lot of rigorous studies, clinical studies, and even trials, and it hasn't really borne out to show a significant benefit. So, some people still opt to take it. I say, it's very well tolerated. It's kind of like a vitamin. The main side effect is the cost. And so some people still, opt to take it. But the evidence, really hasn't shown that there's this, clear like benefit, which is why we don't specifically recommend it. And so, yeah, I would say just be as healthy as you can and take advantage of exercise while, you really don't have any symptoms.
We also have another follow-up questions around health things that people can do ahead of time when they're in this pre-symptomatic stage. We have one attendee who asks, should I be trying to get an MRI and repeating that MRI in future years? What sort of guidance is out there about how frequently people should be getting brain imaging?
So, yeah, I'll take this as a little more MD. I would say, first of all, I don't think insurance is going to go for an MRI
Yeah.
unless, there's another reason why you need an MRI, like you had a stroke, had a brain injury, something. But I think it'll be very difficult to get that covered by insurance as a pre-symptomatic carrier. I think that is definitely an area that's being researched. So if you can get into a research study that is including that, then that's a great way to contribute to improving our knowledge about the disease before symptoms become, um, you know, uh, obvious to a clinician. Because we know from other neurodegenerative conditions that for sure there's damage to the nervous system, significant damage, and before symptoms actually become present in the clinic.
Thank you so much. Our next few questions are around accessing genetic testing. So we have an attendee who's asking, how do you find a doctor who will help with the genetic testing? This person is sharing that they are travel between Arizona as well as Hawaii, but they don't know how to start looking for a place to get genetic testing. What are some ways that they can find out this information?
Yeah, so um, I think we're a little bit biased, but I think in general for this genetic testing process, we do recommend working with folks who are knowledgeable about hereditary ataxias, whether that's a neurologist working with a genetic counselor or other genetics provider or a medical geneticist, someone who is knowledgeable about this process and the genetic testing itself. In Arizona, I'm trying to think of the exact clinics that might be best. But a resource to check out would be the National Society for Genetic Counselors is one place to look to see, and I believe you can search by specialty. It's like findageneticcounselor.org, I believe. So that might be one route. Dr. Davis, do you have colleagues in either of those states that you can recommend or
In Arizona,
recommend?
We also have a list of ataxia centers of excellence around the United States as well around the world. So that might be a place to start. And we have a genetics help page on the NAF website, which I'll ask my colleague Tanoa to drop in the chat, which includes links out to the National Society of Genetic Counselors, as well as answering some common questions around genetic testing and genetic counseling. I will also just share here that the National Ataxia Foundation does have a free genetic counseling and testing program for SCA types 1, 2, 3, 6, and 7. So if you are at risk for one of those types of ataxia and live in the United States, you are eligible for those. We do have a question around free genetic testing, though. If individuals have another type of SCA that they're not eligible for our program, are there any other resources out there for free genetic testing for ataxia types that you're familiar with, or ways they can get subsidized testing?
So it depends on the type of ataxia.
Mhm.
There are some labs that have a program where within a certain time frame of an individual being genetically diagnosed, usually about 5 months out, they will offer up to 2 free genetic tests for family members. This is not all labs, and the terms of it may depend on various details, but that is something that can be available in some cases. In terms of repeat expansion, sponsored or no cost testing outside of what you shared, Celeste, so the National Ataxia Foundation is also sponsoring some genetic testing for Canvas or RFC1 related ataxia, which is currently in a small pilot program technically and only being performed at certain centers. But beyond that, I'm not aware of site-specific genetic testing that would be sponsored. One other sponsored test I just thought of, which we would have to check if the gene is on there, is there's a comprehensive movement disorders panel at Prevention Genetics. It's like 938 genes, so a really broad test, probably overkill for someone who's at risk for a specific condition, but potentially a way to get genetic testing for no cost if that gene is included. Something we do recommend whenever possible is to have a copy of the affected relative's genetic test report to make sure that the clinician is ordering the right test and that if it is a different type of mutation other than a repeat expansion, that we're able to find that exact mutation because not all labs are created equal.
Thanks for clarifying that. It's a complicated thing. It's hard to find information.
Yeah,
Our
absolutely.
next question, we've had a few people ask this. When is the right age to get genetic testing? We have someone shared that they have children under the age of 18 but don't have symptoms. We have someone who shared that their son's 30 years old, not experiencing symptoms yet, wondering if that's too late to get genetic testing. So broadly speaking, is there any recommendations for the best age to start exploring pre-symptomatic testing?
Yeah, I mean, I think like we've said, it's a very personal decision whether to pursue this type of testing, when to pursue this type of testing. Um, in general, as I said before, for conditions where the onset is known to be in adulthood, we typically try not to test individuals who are under 18 to preserve their autonomy, to let them decide if and when they want genetic testing, and also not to over medicalize a child who would not be at risk for many years after that point. And it may impact their insurability in the future as well for things like life insurance, long-term care, disability, if they're tested at a young age before they have the opportunity to look into those types of insurances. After age 18, it's really a case-by-case basis. If someone's been thinking about it for years and years and it's weighing on them and they need to know, that could be at age 40 or it could be at age 20, and really just depending on where someone's at and what their values are and their priorities. Those both may be appropriate times, or one may be appropriate for one person and not the other. So that's also something we offer, is really just the opportunity to talk through this. Just because you meet with a genetic counselor to talk about genetic testing does not mean you have to proceed with it. It can really be a one-time conversation to gather information, work through one's values and belief systems and hopes for this process, and maybe revisit us in a couple of years or never, depending. So we're really flexible, at least in our clinic, about if and how to move through this process. And we're always happy to be supportive how we can.
And that's the case when you meet with an MD as well.
Yes,
It
yes,
doesn't
indeed.
mean you got through the counseling and then you see the MD and then you can still change your mind. I've definitely had patients who showed up on their 18th birthday because they saw all their family members dealing with the disease, and they really wanted to know and and then of course there's other people who we've tested people in their 80s who've had symptoms for a while and then ended up finally getting tested. But so there's no time that's too late.
And then a follow-up question from something you were mentioning, Emma. We have an attendee who's just asked for clarification. You mentioned there's certain types of insurance that people should explore first before exploring pre-symptomatic testing. Could you remind us which of those people should be looking at?
Yes. So these insurance types are certainly optional. No one has to get these insurance types if they're not interested in them, but the supplemental insurances that are not protected under the Genetic Information Non-Discrimination Act are life insurance, long-term care, and disability insurance. And so those are the things that we encourage people to at least look into. Whether they get a policy or not is up to them, but something to explore before starting this process.
And then another technical question about genetic testing. Is this something that people need to give blood for, or would it be a cheek swab or saliva?
We can do any of those for most of these. Usually when we meet with someone at the second visit is when we would do a blood draw, because it's usually in person with the physical exam. But if there's a reason we need to collect a sample later, we can often send a cheek swab collection kit to someone, or a saliva kit for most genes. It sometimes depends on the lab, but for the most part, those are all good options. And it's the same DNA that's in someone's blood that's in their mouth. So no worries about differences between those sample types.
Good to know. Our next couple of questions around symptoms and the onset of symptoms. The first being, we've had a few people ask, what are the earliest symptoms that someone with ataxia might experience or notice? We have people who are wondering if it might be their vision first, or if they're rolling ankles, that might be it, or if it's balance, or if it's fine motor control. From your experience, having worked with people who were pre-symptomatic and are now symptomatic for ataxia, are there any patterns for what symptoms are starting first?
Yeah, so it really varies with the type of genetic ataxia or ataxia. And what I often hear is double vision. Um, but not always, but that is something where it happens and people don't kind of realize that could be the very first thing that leads to all the other balance, coordination issues, issues. It's very dependent on the type. I feel like sometimes speech can be early, but often not. And then balance is often early. And then the episodic types of ataxias can be very confusing because it's like, sometimes some of the episodic ataxias can be the onset is so kind of acute and severe, like such a big sudden change that it can look almost like a stroke. And so, especially like SCA27B, I've heard some of those patients, their kind of first symptom was going to the ER because they thought they were having a stroke. So it can be really, really varied. But yeah, I'll stop there.
And then we have someone who shared that they are pre-symptomatic, um, and they are experiencing some symptoms, but they're not sure if it's the onset of ataxia or if it's something else, like they have the flu or just a bad day. How, in your experience with the people you work with, how do they navigate this in terms of trying to determine what is the beginning of their ataxia journey versus, or ataxia symptom journey rather, versus this is just an off day and the psychological component that comes along with that?
Yeah, maybe I can start with that. Yeah, I know it really does weigh on people, and it's really tough. And I guess I would uh, try to think of the long game, not the short day-to-day kind of game where the symptoms, if they're going to be long term, usually very slowly progressive, and so. You're right. You're not going to kind of wake up and most of the time you don't wake up and say, "Oh, today I've got ataxia." It's kind of this insidious, kind of creeping into your life symptoms that become more apparent. And people kind of say, "Well, 6 months ago I was able to do this, and now it's just getting harder day to day." Or, I'm noticing this. Maybe it's still very mild, but still noticing it regularly. And so I would say that's kind of more of like the level of progression of thinking about it. But it's very tough. I see Huntington's patients where cognition is a very big part of that disease. And I know, some of my patients who are pre-symptomatic, it really can be torturous where, they forget where their keys are. They think this is it, and that's very difficult because it's probably not. Like we all lose our keys, we get stressed, we don't sleep well, things, or yeah, you have a cold, everything's going to be worse. So I would say don't be too hard on yourself. Um,
And we also have resources on NAP in terms of trying to access psychological counseling or other kinds of mental health counseling, not just for people with pre-symptomatic ataxia, but for people with ataxia in general, if you want to chat with someone. Our next question, we had a few very similarly worded questions around things that could potentially trigger symptoms besides having the gene or besides simply aging and time. People are wondering if heat, general anesthesia, or pregnancy, or any other things are known that might speed up or make the symptoms occur earlier than initially would have happened. Is there anything known about this in the literature?
um,
It's a big one. It's a curveball.
yeah, so I think that's a really interesting question. I think sometimes things can seem like they accelerated, but maybe it was more of a coinciding. But I do think when there's a big kind of event that maybe big health event that kind of make changes your level of activity or something like, pregnancy or even an elective surgery where you had like a back surgery or something, and then you had to be more immobilized and have a longer recovery. Suddenly symptoms might emerge, and it might become clear that these are, early stages of ataxia. I think that can certainly happen where um, the disease was kind of already going to the manifestations were already going to happen, but then that like added stress or immobilization or period of time where you weren't as active could bring it out more.
Thanks for clarifying that. We've had a number of people ask how to find studies to participate in ataxia research as a pre-symptomatic person. What would you recommend, or what resources are you or aware of? I will say, while you're thinking on that, that the National Ataxia Foundation does have a Participate in Ataxia research page where we post information about clinical trials, observational trials, as well as more basic research studies that are looking for participants, and we're updating that on a weekly basis. So that might be a good first place to start out, in addition to any other recommendations that you two have.
Yeah. I think clinicaltrials.gov is great. You can type in either ataxia or more specifically the type of ataxia that you or your family member has, and can scroll through there. To cast a wide net, maybe not including the word pre-symptomatic, because that might be phrased differently in each trial description. And so maybe combing through just any trials related to the condition and seeing if they're accepting pre-symptomatic folks might be an option, but we definitely recommend that to patients.
And if you need assistance navigating clinicaltrials.gov, because it can be quite a bit in terms of the interface, we do have a step-by-step guide in terms of how to search for certain information that may be helpful. And with that, we are at the top of the hour. Dr. Davis, Emma, thank you so much for joining us today, for giving us a little bit more information about pre-symptomatic ataxia and answering all of our questions. We weren't able to get to all of them, so if any attendees here have outstanding questions, please feel free to email us at research@ataxia.org. We'll do our best to get back to you and provide you with some information. But Dr. Davis, Emma, again, thank you so much for joining us. We appreciate your time and your expertise.
Yeah, thank you. Thank you.
Thank you all.
And thanks to all of you for being here for the past hour, learning more about pre-symptomatic ataxia. I hope you learned something new today. And wherever you are in the world, good morning, good afternoon, good evening. Have a wonderful rest of your day. Take care, folks.